Introduction. The polycystic kidney diseases are group of genetically heterogeneous disorders and one of the important cause of kidney failure. It is a multisystemic and progressive disorder characterized by cystic formation and enlargement in the kidney and other organs, which includes liver, pancreas, and spleen. It occurs in two forms: autosomal dominant polycystic kidney disease and autosomal recessive polycystic kidney disease.
This is commonly referred to as ADPKD and ARPKD.
PKD.
When you say ADPKD, it is autosomal. Earlier, we used to call it as adult polycystic kidney disease and then childhood polycystic kidney disease. That classification is no more tenable. We don't use that classification. Okay. So we used to call it as AKPD, APKD, adult polycystic kidney disease. This is what we were students used to use that name. But now the inheritance patterns are known. It is no more called adult polycystic or childhood polycystic. It is called ADPKD or ARPKD. Okay.
Okay. ADPKD, autosomal dominant polycystic kidney disease, is one of the most common inherited disorders and the most frequent genetic cause of kidney failure in adults. ADPKD is characterized by progressive formation of epithelial line cysts in the kidney. Cysts are prominently seen in cortical and medullary areas. Patient usually presents in the 4th to 5th decade of life. Extrarenal sites that are usually affected are liver, pancreas, and spleen.
This is very important to note. So patients, those who have the tendency, the genetic mutation is there right from birth, they start coming into clinical appearance or with clinical features only in the late part of life, something around 4th decade to 5th decade. And the ADPKD presents a little earlier compared to ARPKD, which will be even later, which probably you will say in the next slide.
Pathophysiology of ADPKD. ADPKD is caused by mutations in PKD1 and PKD2, which respectively code for polycystin 1 and polycystin 2. Polycystin 1 is a large 11 transmembrane protein that functions like a G protein coupled receptor. Polycystin 2 is a calcium permeable 6 transmembrane protein that structurally belongs to the transient receptor potential cation channel family. ADPKD is inherited as an autosomal dominant trait with complete penetrance but variably expressivity. In ADPKD patients,
what does that mean? Complete penetrance and variable expressivity. You must understand both the terms. Genetics, penetrance and expressivity are two things. What is complete penetrance and what is variable expressivity? Anybody else in the group? If Chaitanya is not able to answer. You haven't studied genetics in your undergraduation. Penetrance is supposing, autosomal dominant disease. 1 of the alleles will be, both parents will be there. One allele is a ADPKD gene, the other is a normal gene. Because this is dominant gene, 50% of the offspring will inherit this allele. That is called the penetrance. Okay, 50%. Suppose they have 4 children, 2 of them will have the gene, but not that all of them develop disease. The disease development is related to expressivity. Genes, though they are inherited, the expressivity may be conditioned by so many factors. And it may happen that one of the 2 who had the gene will develop very early in the disease, and one of the 2, the other one will develop late in the disease. That is called the expressivity. The common thing is, you can see parents who are diabetic. Let us say both the parents are diabetic. The genes of diabetes is a polygenic inheritance, not autosomal dominant or recessive. It's a polygenic inheritance. And the children, offspring are bound to become diabetic. Not all, majority of them. Both the parents are there. But that is penetrance. Expressivity means by their nutrition, by their habits, by their exercise, they may not have developed diabetes even at the end of 70 years, though the genetic propensity is there. So expressivity is a sort of nurture. Penetrance is the nature. Nature and nurture. Nature, coupled with the nurture will produce the expressivity. Okay.
In ADPKD patients, every cell carries a germline mutant allele of either PKD1 or PKD2. However, cysts develop in only a small fraction of the nephron. Cysts are thought to originate from clonal growth of single cells that have received a somatic second hit mutation in the normal allele of PKD1 or PKD gene 2.
What they are saying is here, so the PKD gene is present in every cell in the body, but out of the nephrons, only 1% of the nephrons develop the cyst. Why? There is a normal allele there from the other parent. And if that allele also gets a hit due to somatic mutation, then naturally then there is a double chance, already there is a genetic one, there is a somatic second hit, the mutation was there, and naturally that particular nephron starts developing the cyst. That's the point they are trying to make. Okay.
Approximately 85 to 90% of patients with ADPKD have an abnormality on the short arm of chromosome 16. Is essentially ADPKD type 1. A second defect termed as ADPKD type 2 is responsible for 10 to 15% of ADPKD cases and is found on the long arm of chromosome 4.
Specific chromosome abnormalities are worked out. What is that? Chromosome 16 mutation ADPKD type 1, which presents very early and then poor prognosis. Whereas ADPKD type 2 is responsible for lesser number of people, and this is for about 85% of polycystic disease, and early in the disease, like 40-50, more chances of renal failure and fatality. Whereas ADPKD type 2, the mutation is in the long arm of the chromosome 4. Whereas this is in the short arm of the chromosome. Each chromosome will have a short arm and a long arm. So, sorry. PKD. Yeah, suppose this is the centromere and this is the chromosome. This is the short arm and this is the long arm. Okay. So here, what is happening in the short arm of 16th chromosome, out of the 22 sets plus one set of sex chromosomes, they are numbered as 1 to 22. The 16th one, the short arm mutation, is very common. Fourth chromosome long arm mutation.
Polycystin 1 and polycystin 2 form heteromeric complexes and colocalize in the primary cilium of renal epithelium cells. The primary cilium is long, non-motile tubular structure located in the apical surface of epithelial cells in the renal tubules. Its function was unknown for a long time. However, studies now indicate that the primary cilium may be a mechanoreceptor that senses changes in the apical fluid flow and that transduces them into an intracellular calcium signaling response.
Yeah. Now what is happening? There is the molecular biology they're saying. There is what is called a primary cilium. This primary cilium is a long cilium. It is a mechanoreceptor. It is the one which gets the calcium entry into the cell. Suppose the primary cilium is damaged, the mechanoreceptor damaged, and the calcium entry into the cell gating is at fault. So more amount of calcium and fluid accumulate in that particular cell, which becomes cystic. That is what exactly is saying. Okay.
Bending of the cilium would cause a conformational change in polycystin 1 that would in turn activate the polycystin 2 associated calcium channel, increasing the intracellular calcium concentration and triggering intracellular signaling pathways, leading to normal kidney development, which is altered in this condition.
So that is what exactly is happening here.
Signs and symptoms of ADPKD, which include pain in the abdomen, flank is the most important, most common initial complaint, and it is almost universally present in all patients with ADPKD. Dull aching and an uncomfortable sensation of heaviness may result from large polycystic liver disease. The pain can be caused by any of the following: enlargement of one or more cysts, bleeding, which may be confined inside the cyst or lead to gross hematuria with passage of clots, or perinephric hematoma, UTI, nephrolithiasis, and renal colic, rarely a coincidental hypernephroma.
Yeah, most important thing is pain, dragging pain, weight-like sensation, and then bleeding, hematoma, infections, and nephrolithiasis with associated renal colic. Rarely there could be also associated nephroma. We used to have a patient from Maharashtra by name Mr. Sajjan Rao. He is no more now. He is a patient of ADPKD, and we did the genetic workup also for him. It is of the type 1, that is the short arm of the 4 chromosome is affected. So they live quite a normal life except for the hypertension and the palpable kidney and the dragging pain. But suddenly they deteriorate. They deteriorate so suddenly that within a matter of 3 months, he developed renal failure and died. Okay, he died at the age of around 55, 60 years, if I remember right. So we had to screen the children, the family member, the offspring, because this is a genetic condition. We have to screen the condition. He used to have only one child, Balaji, his name. And that fellow was positive for the ADPKD gene, but somebody is opening the mic. Yeah, your mic only. So ADPKD gene was positive, but he was around 22 years by the time I last see him. Till that time, any number of times ultrasound we do, the kidneys are normal. That means it appears very late, and he was not even hypertensive, the young fellow I'm talking. So this is one experience. I will tell you another case also, which I have as I go about. Okay.
Examination in patients with ADPKD may demonstrate the following: hypertension, which is one of the most common early manifestation of ADPKD, in which increased diastolic BP is the rule. Clinical course in ADPKD is usually more severe early on, then becomes less problematic as the kidney insufficiency progresses. Palpable bilateral flank masses in advanced ADPKD is seen. Nodular hepatomegaly in severe polycystic liver disease is seen. Rarely, symptoms related to the kidney failure, which includes pallor, uremic fever, dry skin, and edema is seen.
Now, there are 3 things. First, commonest manifestation is not a palpable kidney. Start with hypertension, mostly diastolic hypertension. This agenda used to have a diastolic blood pressure of 110, 120 like that. Systolic was around 150, 160 like that. So commensurate elevation of systolic was not there. And it is a little difficult to control. Systolic hypertension is easier to control. Diastolic hypertension is usually difficult to control hypertension. So we have to use at least 2 drugs, sometimes even 3 drugs. You come to the drugs later on in your slides. Of course, we use angiotensin converting enzyme inhibitors and ARBs we use. And palpable bilateral flank masses. So you have to be very careful. So when we were students, we were shown a case of a third-year student, just entered the medical ward. And then there was a case of polycystic kidney. Dr. B. Swami was our teacher, and he was the professor 4th unit, and he asked us to examine the patient. So there were 20 students in the ward surrounding the professor, and he asked, 2 of you only examine, others don't examine this patient. And then very gently you examine. Then we examined, there is a mass-like thing felt. It is bimanually palpable, and it is bilateral. And then he asked what it is. We don't know what it is. We said, we are able to feel something. Then he said, this is a case of polycystic kidney, and all of you cannot examine on the same day because cysts are very highly vulnerable for rupture. If by your inexperience you press the abdomen more in a vigor, sort of interest to palpate the abdomen, you will endanger the patient. Anyway, each one of you, one day you come and gently examine and find out. The patient was in the ward, and all of us could see the patient. That patient was around 55 to 60 years. At that time, there was no genetic workup. No one knows what type of polycystic kidney disease it is. Probably there was no ultrasound even to diagnose polycystic kidney. Only the clinical examination and tomography of the X-ray tomography of the abdomen was the only tool for us to find out those cases. Later on, that case was discussed by in the PG seminar, because PGs also had to know, and we were invited to join that, and they were discussing something about this, which we are not very much aware, but I very clearly, vividly remember the day when he asked us to palpate. I am one among the students who is standing in front. So I was the second one to palpate that, and that's the first time I saw a case of polycystic kidney disease. Okay, go ahead.
Laboratory investigations, which include serum chemistry profile, including calcium and phosphorus, complete blood count, urine analysis, urine culture, uric acid determination, intact parathyroid hormone assay.
Why, Mr. Chaitanya? Why do you want to do a IPTH? IPTH, intact parathyroid hormone. Why do you want to do that? Did you hear of renal osteodystrophy? Renal osteodystrophy. When there is renal failure, there will be a derangement of the bone metabolism also. That is because of, there will be, due to the renal failure, there will be parathyroid hormone will be excess. The excess parathyroid hormone draws the calcium from the bone, and that excess calcium produces nephrolithiasis and aggravates the renal failure. So every patient of renal failure, you are bound to examine IPTH assay. What is IPTH? IPTH is intact PTH. PTH is a very labile hormone. It then becomes disintegrates very fast. You have to put the serum blood sample, of course serum, in an ice box and send it. You cannot just like that send like blood urea and creatinine. You have to send it in ice. That is the practical point related to IPTH. Okay? To rule out renal osteodystrophy.
Diagnosis typically made from a positive family history consistent with autosomal dominant inheritance and multiple kidney cysts bilaterally. Renal ultrasonography is often used for pre-symptomatic screening of at-risk subjects and for evaluation of potential living-related kidney donors from ADPKD families. Ultrasonographic diagnostic criteria for ADPKD1 are as follows.
Just one second, hold on. Here, one important point today is the kidney transplants are becoming common. If there is a patient or person who is interested to donate the kidney, if there is a family history of polycystic kidney in that particular family, either parent or grandparents having polycystic kidney, then we are bound to screen the donor for ADPKD both with ultrasound and by genetic marker. Then only we can consider the kidney for transplant. Otherwise, what will happen? You will think it is a normal kidney, you transplant it. In the course of time, it becomes a cystic kidney and it is no use. So that is very important. That's one point. Second thing is siblings or children of the affected parents should be screened. Suppose there is a patient, his brother or sister are there, they must be screened. Like that, suppose there is a parent with polycystic kidney, just like the Sajjan Rao, his only son Balaji Rao has been screened and found negative till the time I last followed him. So that is done by ultrasound. Ultrasound is the diagnostic tool, not MRI, not MRA, and not CT. It's very rarely they are required, unless you are trying to do something more related to the renal failure. Most common mode or the best available mode of diagnosis, imaging, is ultrasound of the abdomen. Okay. Now, how do you classify AKPD1, ADPKD1? You go about.
Ultrasonographic diagnostic criteria for ADPKD1 as follows. At least two cysts in one kidney or one cyst in each kidney in an at-risk patient younger than 30 years. At least two cysts in each kidney in an at-risk patient aged 30 to 59 years. At least 4 cysts in each kidney for an at-risk patient aged 60 years or older.
Why younger fellow 2 cysts and then the younger fellow the criteria are stricter compared to 4 cysts are required in a 60-year-old, whereas 2 cysts, one in each kidney, are required in 30-year-old. Can you say why? So as people age, there is a tendency for a normal cyst formation also in the kidney. So that is why the elder the patient, the renal cysts are quite common, simple renal cysts. They can be 1 or 2 renal cysts may be there. Anything less than 2 cysts, that is, less than 2 means only 1 or 0. So if you have 1 cyst, it cannot be polycystic kidney. The very fact it is poly means there must be many. The older the patient, the more number of cysts are required to confirm it is polycystic kidney. This is all in an at-risk patient. Who is an at-risk patient? A patient who has a family history of polycystic kidney. At-risk means what? That is the thing. Okay.
Ultrasonographic diagnostic criteria for ADPKD in patients with a family history but unknown genotype are as follows. 3 or more unilateral or bilateral renal cysts in patient aged 15 to 39 years. 2 or more cysts in each kidney in patients aged 30 to 59 years. Fewer than 2 renal cysts in the finding provides a negative predictive value of 100% and can be considered sufficient for ruling out disease in at-risk individuals older than 40 years.
So that's very important. There is an at-risk patient and he is already 40 years. He did not develop cysts of 2 or more. It is less than 2. He has got 1 cyst. It rules out the diagnosis. He is not a candidate for developing adult polycystic kidney disease. So fewer than 2 means you have what? Only 1 cyst or none. None it rules out. There is no cyst or only 1 cyst in a 40-year-old at-risk patient. It rules out the diagnosis. Negative predictive value is if this finding is there, it rules out the disease. Negative predictive value. Positive predictive value rules in the disease. Okay.
CT. Other investigations which include CT scanning is not a routine and useful in doubtful pediatric cases and in complicated cases. MRI, which is in routine, helpful in distinguishing renal cell carcinoma from simple cysts. Criterion standard to help determine renal volume for clinical trials when testing drugs for ADPKD, and best imaging tool for monitoring kidney size after treatment as an indication of disease progress. MR angiography is not routine, preferred imaging technique for diagnosing ADPKD related intracranial aneurysms. Management. Controlling of blood pressure, which include drugs or AC inhibitors and ARBs. The HALT PKD trial was set to evaluate the impact of intensive blockade of renin-angiotensin aldosterone system and levels of blood pressure control and progressive renal disease. This trial found that rigorous blood pressure control could slow the cyst growth. Control abnormalities related to kidney failure. Drugs to maintain electrolyte levels, which include calcium carbonate, calcium acetate, sevelamer, lanthanum carbonate, calcitriol diuretics, and blood pressure medications.
Now here you stop. Now, when we treat the ADPKD, anyway we cannot stop the cyst. What can we do? We can prevent the renal deterioration, renal failure, and we can control the blood pressure. The more you control the blood pressure, there will be a delay in the development of renal failure. What drugs I use? I have to use an ACE inhibitor or an ARB. What are the ACE inhibitors available? Enalapril, ramipril, captopril, lisinopril. In our country, we now commonly use ramipril. Okay. ARB, valsartan, telmisartan, losartan, irbesartan, candesartan, olmesartan. You can use either telmisartan or olmesartan or losartan. We don't use much of valsartan and irbesartan and candesartan in this country. So this is very important. So either use losartan, olmesartan or telmisartan, enalapril or captopril or lisinopril also you can use. Ramipril is the commonest used drug. The second group of drugs are those which are used in any renal failure. Like, to maintain the electrolyte value, you have to give calcium carbonate. All patients of renal failure must get calcium carbonate. This is to prevent the absorption of phosphate. Hyperphosphatemia is a feature there. Calcium carbonate combines with the phosphate in the food and then that gets excreted. Calcium acetate also does the same thing. Sevelamer, available as Rivalmer. Rivalmer is a drug name. This is also a phosphate binder. There is another phosphate binder for the, there is an Lance phos. There is another phosphate binder. These phosphate binders are used to prevent the absorption of phosphate, either by giving calcium carbonate and blocking phosphate, or there could be direct drugs like Sivalmir and Lance phos or something like that to prevent phosphate absorption by phosphate binders. Lanthanum carbonate, not lanthanum carbonate. Lanthanum carbonate is also a phosphate binder. Calcitrol is used, nasal spray is used. This is the synthetic calcitonin. Calcitrol can be used and diuretics can be used. This is to treat the hypercalcemia associated with that. Of course, blood pressure medications. Okay.
Lipid-soluble antibiotics against common gram-negative enteric organisms include trimethoprim, sulfamethoxazole, quinolones, and chloramphenicol, and are preferred for cyst infection because most renal cysts are not connected to glomerular filtration, and antibiotics that are capable to penetrate the cyst walls are likely to be more effective. Treatment often requires 4 to 6 weeks.
The point here is, if you give an antibiotic, it gets filtered, and the cyst is not connected to the filter. Anyway, there is no filtration in the glomerulus associated with a cyst, so it's not going to help. So what you have to give? You have to give drugs which penetrate the cyst wall, like gyrase inhibitor, like quinolones, like your fluoroquinolones, ciprofloxacin, or carbofloxacin, like drugs, or TMX and SZ, sulfamethoxazole, trimethoprim combination, chloramphenicol. Nobody uses nowadays because of its blood disgrace acid. So these are the two groups of drugs. And how long I treat? Around a month you have to give. Okay. Surgical intervention.
Surgical intervention. Surgical intervention in ADPKD includes the following: surgical drainage, usually in conjunction with ultrasonographically guided puncture in cases of infected kidneys or liver cysts not responding to conventional antibiotics. Open or fiber optic guided surgery for excision or drainage of outer walls of cysts to ablate symptoms. Nephrectomy is last resort for pain control in patients with inaccessible cysts in renal medullae. Partial hepatectomy. It is to manage massive hepatomegaly liver transplantation in cases of portal hypertension due to polycystic liver or hepatomegaly with unresectable areas.
So if you have to remember one point, liver cysts develop very much more frequently in women with polycystic kidney disease, unlike men. The occurrence of polycystic kidney disease is slightly more in men, but the lady who develops a polycystic kidney, she is at a greater risk of a huge hepatomegaly with cystic change, unlike men. That is a very important clinical point in it. Woman with polycystic kidney, you must look at the liver. Okay.
Patients with ADPKD who progress to end-stage renal disease may require the following procedures, which include hemodialysis, peritoneal dialysis, and kidney transplantation.
This together is called the RRT, renal replacement therapy. RRT means you do the function of the kidney by some other method. That is hemodialysis or peritoneal dialysis or renal transplantation. Renal replacement therapy is essential. Okay.
Prognosis. The ProPKD score predicts risk of progression to end-stage renal disease in patients with ADPKD. The score is calculated on the basis of following factors: male sex, 1 point; hypertension before 35 years of age is 2 points; first urologic event before 35 years of age is 2 points; PKD2 mutations is 0 point; and non-truncating PKD1 mutation is 2 points. Truncating PKD1 mutation is 4 points.
Truncating PKD1 mutation is the 16th chromosome short term, long arm mutation. 16th is short term, 4th is the long. Okay. Now this is you score them using the ProPKD score, and now you grade them.
Risk categories on the basis of points total are as follows: 0 to 3 points, is low risk. Median age for end-stage renal disease onset 70 to 71 years. 4 to 6 points, which include in intermediate risk. Median age of end-stage renal disease onset is 56 to 57 years. 7 to 9 points is at high risk. Median age for end-stage renal disease onset is 49 years. A pro-PKD score of 3 or less eliminates evolution to end-stage renal disease before 60 years of age with a negative predictive value of 80 to 81 to 82%. A score higher than 6 forecast end-stage renal disease onset before 60 years of age with a positive predictive value of 90 to 91%.
Yes, so this is very important. Patients will ask, sir, you have said I have a genetic disease. Will it go to my son? Yeah, you have to screen your brothers, sisters, as well as your son and daughter. That is one thing. And other thing is, what will be my prognosis? Will I have a normal life? Yeah, let me do the pro-PKD score. If the pro-PKD score is less than 3, unlikely you will have end-stage renal disease before 60. If it is more than 6, very likely you will have renal disease, end-stage renal disease before 60. Positive predictive value is confirmatory about the occurrence. Negative predictive value is the ability to rule out. So if the person has got less than 3 pro-PKD, his chances of getting end-stage renal disease are very less. So only 81.4%. That is 82% chance he does not develop. Only 18% chance he may develop. Whereas if you have a score of 6 or more, there is a 91% chance he will develop. There is only a 9% chance he will escape. These are the statistical probabilities based on study.
This is the image of polycystic kidney disease.
Bilateral polycystic.
Bilateral.
It need not be bilateral. It could be unilateral also. So sometimes bilateral. Or one kidney may be very large, the other kidney may have few S's. Okay. ARPKD.
Autosomal recessive polycystic disease. ARPKD is a significant hereditary renal disease in childhood with an estimated prevalence of 1 in 20,000 live births. Mutations in a single gene, PKHD1, are responsible for all the clinical presentations of ARPKD. Cystic dilation of collecting duct is seen unlike in ADPKD.
But what is happening there? There it is this glomerular damage. It is the collecting duct. So more about the collecting duct damage it is, and it is in the younger people, and it is a recessive disorder. Less frequent than that. That is around 1 in 1,000. This is 1 in 20,000 live births. PKD, adult PKD with the dominant autosomal dominant inheritance is the occurrence is 1 in 1,000. Here it is 1 in 20,000 live births. Okay.
Classic ARPKD is generally diagnosed in utero or within the neonatal period and characterized by greatly enlarged echogenic kidneys in deceased fetuses. Reduced fetal urine production may contribute to the Potter sequence, which include oligohydramnios, fetal compression, and pulmonary hypoplasia.
Correct.
Concerns beyond neonatal period include systemic hypertension, progressive renal insufficiency, portal hypertension due to hepatic fibrosis. Diagnosis. Ultrasonography, CT, and MRI all can be used for diagnosis. Ultrasonography reveals large echogenic kidneys with poor corticomedullary differentiation. The diagnosis can be made in utero after 24 weeks of gestation in severe cases. The absence of renal cysts in either parent, particularly if they are greater than 40 years of age, on ultrasonography helps distinguish between ARPKD from ADPKD in older patients.
Correct. So here it is not an autosomal dominant one. So parents may be normal. Maybe they earlier, first filial generation, second filial generation. Grandfather, grandparents might be having, and it is a recessive one. So one generation can escape the disease, and it will come out in the next generation. Okay.
Clinical, laboratory, or radiographic evidence of hepatic fibrosis. Hepatic pathology demonstrating characteristic ductal plate abnormalities. Family history of affected siblings or parental consanguinity suggestive of autosomal recessive inheritance is helpful. The lack of mutational hotspots and the large and complex genomic structure of PKSD1 make molecular diagnosis difficult. However, pre-symptomatic screen of other at-risk members in a family with already identified ARPKD mutations is straightforward and inexpensive. Treatment. There is no specific therapy for ARPKD. Appropriate neonatal intensive care, blood pressure control, dialysis, and kidney transplantation increases survival into adulthood. Complications of hepatic fibrosis may necessitate liver transplantation. Patients with severe Caroli's disease may need portosystemic shunting. Other diseases with cystic phenotype, medullary cystic kidney disease, which is
I think
autosomal
what I suggest is this table everyone can read on their own. You circulate the PPT, and this is to differentiate polycystic kidney from other cystic kidney disease. And that's all you have, I think. Certain things you have picked up very well, and you have made a summary. Probably you read the first few pages, and later on you have had no interest to continue in the detailed discussion about this one. But it looks like that. So it's an inherited disease that you have told, a bilateral renal. See the image below, the condition is divided two forms. We know ADPKD and RPKD. Earlier we used to call adult polycystic and childhood polycystic, which is no more tenable. Most inherited disorders in the human being. If you have any inherited disorders in humans, this is the most common inherited genetic disorder of the human beings with frequent kidney failure. 6 to 8% of people who undergo dialysis are candidates of this disease. It is multisystemic and progressive disorder, cyst formation and enlargement in the kidney and other organs. We have shown that liver, pancreas, and spleen. I told you here, the moment it is a woman patient, the chances of propensity for liver cysts are much more. Okay, they survive up to third or fourth decade. Some people even go up to the sixth decade without any need for renal replacement. By around 60 years, 50% of the patients will require some form of renal replacement therapy. What is renal replacement therapy? Peritoneal dialysis, hemodialysis. Please close your mic. Peritoneal dialysis, hemodialysis, or renal transplantation. Okay, that is what. And then you have mentioned these things: pain in the abdomen, flank or back, most common initial complaint. Bleeding may be there. There could be recurrent urinary tract infections, nephrolithiasis, renal colic, coincidental hypernephroma. That also you mentioned. Most important clinical feature is diastolic hypertension and palpable bilateral flank mass, nodular hepatomegaly, symptoms related to the kidney failure. Okay, what do? I measure chemistry profile, including calcium and phosphorus. Here is one point that you should know. There is what is called the Ca into pH, Ca into P product, calcium into phosphate product. Normally, calcium is around 8 to 9, phosphate is around 4. So 8 into 4 is 32, 9 into 4 is 36. If this Ca into P product exceeds 50, it is suggestive of chronic renal failure. You understand? You do the Ca into P value. Calcium multiplied by the phosphate should not be more than 50. This is to diagnose renal failure, not polycystic kidney. And CBC, urine analysis, urine culture, uric acid determination, because if at all stones are formed here, normally calcium oxalate stones are formed. Here there are the uric acid stones. Because of the inability of the kidney to excrete uric acid, there will be hyperuricemia, and the stones of polycystic kidney disease are uric acid stones compared to the general stones, which are calcium oxalate stones. Intact parathyroid hormone, I told you to look at the renal osteodystrophy. Okay. And also you should screen the potential kidney donors for that. This you have not mentioned, very important classification. This is called the Kodayaki classification, kidney diseases. Research, this one is there. stage 1, stage 2, stage 3, stage 4, stage 5. You have to classify the renal failure into which stage. Stage 1 renal failure is estimated GFR of the 90 ml per minute or more. Stage 2 is GFR between 60 and 90. Stage 3 is 30 to 60. Stage 4 is 15 to 30. Stage 5 is GFR below 15. People who require renal replacement therapy are those who are in the stage 4 and stage 5 category. Okay, I will show you how to work out that. Can you see this? It changed this one. Can you?
Yes, sir.
Yeah. This is from the Davidson. How to estimate the GFR? Because you don't do that. You only do serum creatinine, urea, and be done with it. But never do that. Today days have changed. For the last 15 years, we have been telling students to estimate the eGFR. eGFR is estimated GFR. How do I do this? There are two formulae. One is called the cockpit formula. The other is called the MDRD equation. Either you can use. And if you have Medicalc, it straight away calculates. Okay. Now, modified diet and renal disease MDRD equation. If you go to that site at www.renal.org by eGFR or to my site also, this particular calculation is available. Both the creatinine clearance method or by the eGFR by the MDRD equation. So what all I need to know? So you have to do 175 multiplied by creatinine in micromoles per liter divided by 88.4 to the power of minus 1.154 multiplied by age in years to the power of minus 0.203 into, who can remember this? Nobody can remember. So what all you need to know? You need to know serum creatinine, you need to know the age, you need to know the gender, you need to know if they are negroid race. Anybody other than negroid is called others. Even if you are a European, Caucasian, or a Hispanic or Asian, you are non-negroid. Hispanic means Spanish people. Okay, Caucasians are people who are in the Europe, or Chinese, they are a different origin, Mongolian, Mongoloid race, or Asians, they are all non-Negroes. If it is a Negroid ratio, the chances of renal failure are higher, so you have to have multiply it by 1.21. If other races, just multiply by 1. That means you don't have to do any multiplication. Okay, so what are the things that I require? I require to know the patient's serum creatinine. I require to know the patient's age. I require to know the gender, and I require to know the black or non-black. So then you see, modified MDRD equation also can be used, and this is available. If you know what is Medicalc, and just type the number, the creatinine number, the age of the patient, and then the gender of the patient. I'll show you. Now this is Medicalc, is the medical calculator. You can see the equation. Okay, I went at renal, I wanted to know the eGFR, electrolyte, medical diseases, the medical endocrine pressure, renal clearances. Okay, so you can go, so many are there. eGFR master, you can click. Okay, what is it asking? Patient's age, gender, ethnicity, body weight. This is not modified. We'll go to the modified eGFR, MDRD4 or Cockcroft. Cockcroft also you can use, or MDRD also you can use. Okay. Now you require what is the patient's age? What is the age of the patient? Let us say 65. And then gender, let us say female. And let us say white or non-black or black non-black. Creatinine milligrams or millimoles. You can type it here. Creatinine, let's say 1.2, 1.3. So do you think 1.3 is abnormal creatinine or normal creatinine?
Abnormal.
Supposing I give you a patient's report of 1.3, is it renal failure or normal? Is it normal or not? Normal or abnormal?
Normal. Sorry,
Now-
sir. Get.
Now you calculate.
Hello.
43.8. Stage 3 renal disease. You see, you said normal. 1.3 creatinine, you said normal. It is stage 3 renal disease. Supposing I change it to men and I recalculate. 59, much better. Same creatinine in men is a lesser renal failure. Same creatinine in woman is more renal failure. Okay? Supposing I just say 1.6, which many of you clinicians, PGs and doctors may say it is normal. You see, it will be 4, already stage 3 disease, stage 4, nearing stage 4 disease. That less than 30 is stage 4. The moment I make it black, it is even better. Blacks are better off. Suppose we are worse off. Female gender, non-black gender, age, I change this to 70. Okay, make it a female and non-black. And you see what will be the calculate? 33.9. Now, the moment I make 2 milligrams, it will be renal replacement therapy will be indicated 26. So anything less than 30 is stage 4, less than 15 is stage 5. Supposing make it as 2.5 or 2.6, now you see 19.4 or 2.8. So nearing to the very severe renal disease. CKD class it is giving. So this you have to use. This is called MDRD4. You use it. This is how you use it. Patient's age, gender, ethnicity factor, creatinine value, either in milligrams or millimoles. And then automatically MDRD4 value will come, EGFR, and the stage also will come. You can print it also and give it to the patient. So don't just look at the creatinine value and say, I will say a creatinine of 1, which nobody says it is renal failure. Okay. Even then it is already stage 2 renal. Less than 60 is stage 3 renal disease. 90 to 60 is stage 2 renal disease. Already stage 3 renal disease. 1 milligram of creatinine. Who will say 1 milligram of creatinine is stage 3 renal disease? No clinician will say. So you have to do this. Okay. This is not on one occasion. At least on 2 occasions you have to measure the serum creatinine, and it should be around that. Suppose suddenly it is 1.2 or 1.8, and it is normal afterwards. It is not chronic renal disease. So you have to understand this very well. Okay. Now let us go back to our sharing. Okay. So this is how we calculate. And the gradations also I have shown you how to grade it into different things. Above 90, normal. 90 to 60, stage 1. Less than 60, stage 2. Okay. Less than 45, stage 3. Less than 30 is stage 4, stage 5. 30, stage 4. Less than 15, stage 5. Okay. Now, you see here, you have said no, there can be cysts in the pancreas that can lead to what is called the MODY, the maturity onset diabetes of the young. MODY. It could be a MODY type of diabetes also may be there. Okay, all other things are what you have said. More importantly, you have to pick it up that it is very common, as much as 1 in 1,000. And then there are 2 types of inheritances, PKD1 and PKD2. You have said that ESRD occurs more frequently in PKD1 rather than PKD2. That is important. And then the classification, you have said how many cysts you should have. That also we have discussed. And then management comes. Most important thing is the blood pressure management. And then the CKD targets, they should be measured. Particularly EGFR should be measured. And you should target the blood pressure to something around 110/75. And then autosomal recessive is more a pediatric disease. And you can see here the renal cysts on both sides, bilateral polycystic kidney. Okay. In this particular article, can you see the article now? which I gave you?
Yes, sir.
Yeah. So ultrasonography is diagnostic. CT, MRI, and MRA are not required. You have forgotten to mention about the complication of cerebral aneurysm. So you just said in one place, MRI is used to diagnose, MRA is used to diagnose cerebral aneurysms, but you have not mentioned anything there. Around 5% of people with PKD may have cerebral aneurysms, and rupture of the berry aneurysms can result in subarachnoid hemorrhage. So in that case, you need to do an MRA of the brain and then do that. Okay. So MRA, this 1 to 3 doses you have put it, 3, then 2 or more, that also. Familial history, yeah. Indications for MRI, family history of stroke or intracranial aneurysms, development of symptoms suggesting intracranial aneurysms, and job and hobby, which is a very important. Loss of consciousness may be lethal, except a bus driver or an airplane driver or a scuba diving trainer. These they cannot afford to lose the consciousness suddenly. And then past history of intracranial aneurysms, you must do an MRI. What do? Control the blood pressure with ACs, ARBs, and use renal failure drugs like sevalamer, rivaroxaban, lanthanum carbonate or calcium carbonate, calcitrol, diuretic, and then calcitonin also can be used. Treat URIs, calcitonin for hypercalcemia. Cysts have to be treated with infection which penetrate the cyst membrane, like the gyrase inhibitor, ciprofloxacillin, levofloxacillin, or trimethoprim. You have said that hematuria. What do I do with hematuria? Suppose polycystic kidney fellow comes with hematuria. You have to give him rest, more fluids, and wait. In a matter of 5 days to 1 week, the hematuria subsides. You don't require to do any extra maneuver. Abdominal pain, enlarged kidneys are there. You do the cyst drainage or laparoscopic guided cyst wall opening, or sometimes nephrectomy or partial nephrectomy. Another important thing is cardiac valve infections can occur in people who have already having a valvular disease with polycystic kidney. A patient is there, is a valvular disease patient, has polycystic kidney, subacute bacterial endocarditis is a possibility. You have forgotten to mention very important newer generation drugs called the tolvaptan, vasopressin 2 receptor inhibitors like tolvaptan. Lot of literature is available on that. Surgical drainage you mentioned, and more importantly, tolvaptan should be considered. The renal replacement indicates only the three things: hemodialysis, peritoneal dialysis. Pathophysiology we have discussed. Less than 1% of the nephrons only harbor these ones. Approximately 85 to 90% of ADPKD is a short-arm chroma of the 16, and in the remaining it is the long arm of the 4 chroma. There are other abnormalities also, renal genetic abnormalities, which are rarer. So sometimes, plasma vasopressin levels may indicate the severity of the urine concentrating ability of the AKPD. Because concentrating ability is lost, urine becomes dilute, hypoosmolality in the plasma. Hypoosmolality stimulates the osmo receptors, and vasopressin secretion will be more. Renal, plasma vasopressin may be an indicator of the concentrating ability of the kidney. Bleeding is because of the neoangiogenesis and the fragile blood vessels break. Etiology we know, the genetic etiology. Polycystin 1 and polycystin 2. We have mentioned about that. Epidemiology, okay, we can skip. Prognosis. When do I say that the patient will have bad prognosis? PKD1 genotype, very large kidneys, episodes of gross hematuria, severe and frequency of renal infection, presence of hypertension, multiple pregnancies, black racial background, and male gender. These are associated with bad prognosis. Okay, adult PKD2 is ADPKD2 is a milder disease. Cardiovascular pathology and infections account for 90% of the deaths treated with hemodialysis. Okay, so that's very important. And rare cause of mortality is subarachnoid hemorrhage due to intracranial aneurysm. Okay, half of the patients died due to cardiovascular accident problems in a disease. So what are the causes of death in this patient? Cardiovascular problems, infection, cardiovascular factors, infection, CNS hemorrhage, that is the berry aneurysms, uremia, not a direct cause, and miscellaneous causes. We may think that they die of renal failure, but majority of them die of infections and then cardiac problems. Okay, pro-PKD score you have given, risk levels also you have shown. Serum phosphate levels have to be understood, because the moment the phosphate starts rising, our Ca into P ratios, P values more than 50, then the hazard is much more. You have to educate the patient about the disease, particularly, you have in India, or anywhere for that matter, we have a habit of having children on our abdomen and then playing with them. So never allow the child to sit on the abdomen or stand on the abdomen of a polycystic kidney patient. This is a practical point. You have to insist that no weight should be put on the abdomen. Particularly children are carried on the abdomen. We lay down and then keep the children on the abdomen and then start playing with them. If it's the older child, the weight will be too much. The cyst can rupture. Very important. Pain mostly due to enlargement, due to bleeding, due to infection, due to nephrolithiasis or coincidental hypernephroma. Physical examination, hypertension and palpable renal mass, diastolic blood pressure, very important. You have to examine the liver, particularly in women, and there will be nodular hepatomegaly. Symptoms of renal failure must be looked at. End-stage renal disease is a common complication of ADPKD, and polycystic liver disease should be suspected, particularly in the women. There could be cysts in the spleen and pancreas. Pancreatic cyst can lead to MODY type of diabetes, maturity onset diabetes of the young. Cerebral aneurysms are around 7% of people develop cerebral aneurysms. You have to use MRI to find out. Nephrolithiasis, stone formation. The stones here are not oxalate stones, but they are uric acid stones, as you can see, very commonly because of the high urate levels in these patients. So other conditions are acquired renal cyst, autosomal recessive polycystic disease, medullary cystic disease, and then simple renal cyst. So usually when we do an ultrasound, we find out the patient the sonologist report, there is a simple renal cyst, a single cyst in one kidney. What you need to do is just follow it up, and then you don't have to really worry about that. Other cystic diseases, the kidney, Von Hippel-Lindau disease are the differential diagnosis. Approach, do ultrasonography, serum chemistry profile, complete blood count, urine analysis, urine culture, uric acid, phosphate, mostly including calcium and phosphate. You have to do not only just urine routine biochemistry, you do the serum calcium and phosphate also you do, and IPTH for the renal osteodystrophy. Another important thing is hematocrit, PCV may be raised. Why? Because the increased erythropoietin secretion from the cyst that stimulates red blood cell production. There could be a polycythemia and then hematocrit. One of the rare causes of polycythemia, secondary causes, is polycystic kidney disease. And there are now markers are available, biomarkers, biochemical markers are available, which can, in the urine itself, you can do urinary peptidomic biomarker scores are superior to that of other biochemical markers. Just to take the urine and look at the peptidomic biomarkers, which are not available in all centers. Genetic testing is required to rule out whether it is ADPKD or ARPKD, and in the ADPKD, whether it is PKD1 or PKD2, because the prognosis depends upon the type. If it is PKD1, more severe, PKD2, screening for endocrine aneurysms must be done in all patients, particularly who have families, cerebral aneurysms, or people who have headache or who have intracranial bleed. Ultrasonography is the diagnosis of treatment choice, and then CT MRI are reserved only for people. Okay. Considerations: you treat hyperkalemia, treat hyperphosphatemia, hypokalemia, Hyperparathyroidism and metabolic acidosis are the complications. Of course, manage the blood pressure. Tolvaptan is a selective vasopressin B2 receptor antagonist, and it is approved for treatment of adult polycystic disease. There are other investigative therapies are also going on. Metformin, long-term use of metformin is supposed to be beneficial for people with polycystic kidney disease. There are also called drugs like octreotide and lanreotide, somatostatin analogs are also useful, being tried in different studies. There is another derivative of acetyl salicylic acid, which is called salicylate. Salicylate is a prodrug of the salicylate. It also is supposed to increase the renal function. So investigative therapies, metformin, somatostatin analogs, and salicylate prodrug, salicylate, are the investigative treatment. Approved treatment, tolvaptan, to reduce the fluid overload because of the high vasopressin. And this vasopressin, excessive vasopressin, retains the fluid and increases the chances of renal failure. And then if you give tolvaptan, the vasopressin receptor is inhibited, so the high vasopressin levels are not going to damage the kidney and the patient. Most important, what diet people will ask, because hypertension is there, low salt diet can be recommended. Other than that, there is no other diet restriction. What sort of things to be avoided? Playing with children on the abdomen, contact sports like football or hockey or wrestling or anything where there is a chance of the patient injured by the opponent with the hand on the punch on the abdomen or the back, which can result in rupture. This is the advice you give. Blood pressure control, we already mentioned. Avoid calcium channel blockers. Why? Calcium channel blockers have a tendency to retain fluid. Although there is fluid overload here, you don't want to give calcium channel blockers. You have to use ACE inhibitor or ARBs. Beta blockers can also be given. Diuretics can also be given, not calcium channel blockers. And you should be periodically monitoring the when you are using ACE inhibitor. ARBs, hyperkalemia is a problem. So you have to look at the serum potassium and frequently monitor the chemistry. Infections, mostly gram-negative, and you have to treat with the drugs which we have already considered. Hematuria, only treatment is rest and hydration, and then it resolves automatically. Abdominal pain, surgical intervention. Non-steroidal anti-inflammatory drugs should not be used for the abdominal pain because it endangers the kidney and it is not somatic pain. It is more a visceral pain. So surgical, this is you see the huge liver with cysts in a woman and associated polycystic disease of the kidney also. Okay? Massive polycystic liver in this patient. Partial hepatectomy may be considered in such cases. So ensure a patient with AKPD, that is adult polycystic kidney disease, who is a non-hypertensive treatment, has normal renal function, undergoes blood testing and ultrasonography every 1 to 2 years. That means he has a genetic predisposition, no ultrasound evidence of, there is evidence of ultrasound evidence of ADPKD, blood pressure is normal, renal function is normal, and you have to have blood testing and ultrasonography repeated every 1 to 2 years. Okay, tolvaptan, we have considered ACE inhibitors, we considered antibiotics, we considered renal failure drugs, we considered, and that's all is there. And individual drugs are dealt in this article hereafter. Probably with this we can stop it. Now, when I give an article, I expect you to read the entire article, not read only the clinical practice guidelines.